There is a history that those of us in behavioral health care share, a history of pain and of promise.
We're very fortunate that we have people who have a wealth of history, who actually have been, in some cases, at the same center they're at now all of their professional lives, have seen those centers develop from the very beginning, and have had to make all the evolutionary changes and all the evolutionary decisions in real time. And now we have an opportunity to capture some of their thinking behind that, some of the history and some of the values that went into some of those tough decisions.
When we started, community mental health meant community mental health for everyone, and that meant people who were poor, and it meant people who had average amount of resources. It meant people who were uneducated and people who were educated. But gradually over time, probably as a result of funding and other changes, I've seen a lot of mental health centers become organizations that serve especially chronically mentally ill individuals in their community. And yes, they still focus on the community for those people, but I think the larger vision, the provider for the whole community, the organization that can reach into people's retirement years, young adult years, families, that's changed for a lot of organizations, and I regret that.
Seriously, a lot of notions. One that I remember very vividly was our responsibility from cradle to grave, so that we had a catchment area or a defined population, and we were responsible for their mental health from the time they were born until the time they died. And that was a brand new concept.
I saw the value of the 5 essential services coming into play, the value of being able to work with individuals through a team approach, and that's where I got very excited.
We were very idealistic, and a lot of us were getting into this business because of that idealism, and I think that it was based on the old public health model that was really important to us, that we were going to make a difference in our communities, and that and so we were very mission driven and vision oriented, and the economics of the business took a back seat actually to a lot of what we did. I mean, we were always prepared to do more with less.
There were really a variety of simultaneous movements going on that I think were co-occurring with the community mental health movement. I mean, there was the civil rights movement, there was the women's movement, there was the student kind of counterculture movement. I mean, all that stuff's kind of happening simultaneously.
This heightened awareness resulted in growing expectations for effective solutions.
In the years 1970 to 1980, the largest number of Supreme Court cases in any class for mental health. We, for years, have characterized the de-institutionalization of state hospitals and the development of community mental health centers as an economic movement on behalf of the states trying to save money. In fact, it was a civil rights movement. It was, these people have rights, they have, quote, least restrictive alternative, which really became a watchword in community mental health much after the development of the initial thoughts. And it came out of the law. The notion of the right to treatment or the right to refuse treatment. All of these cases, starting with Wyatt versus Stickney, were all cases that, interestingly enough, were in large part also financed by the federal government.
And then in the early 1980s, the block grant legislation was passed. And this is very important to keep in mind and to remember, because it really altered the landscape of the way we were practicing at that time. It significantly restricted the ability to continue the vision of the community mental health system as it was enacted. Basically what happened was the dollars that used to go directly from the federal government to the community mental health center in the local community was diverted to the states. And what happened was that the dollars that were going were basically rolled together into one lump sum. And before they were allocated to the states, they were reduced by 25%, about 20, give or take a little bit. And then they were allocated to the states, and said, and the federal government then said to the states, you run the system and you provide the funding.
The notion was that you were to be replacing those funds from patient consumer fees, insurances, or from other community funds, the United Way or local funds of any kind. That was the master plan, but we found it very difficult to replace those funds as we lost the staffing money. And particularly in the low-income communities and in inner cities where there just wasn't the revenue base.
It's getting harder and harder to find some place to cost shift these things to. That's the bad news. The good news is with an organization like MHCA, people have good ideas for new markets, creative ways of going after new funding and new populations.
As the financing changed and almost the vision, if you will, or lack of vision, if you will, of the financiers, the governments, changed with each change in bureaucrats. It was never quite clear what we were intended to do.
Despite funding stream changes, despite regulatory changes, I find myself unable to give up the piece that the mission that our organization and other organizations were designed to serve the whole community. And my attitude became, if the government won't pay for this, then who will? I know it's valued, I know it's making a difference. What other ways are there to get these services paid for, to get this service delivered to the people who need it or want it? And I think that's where the emphasis on becoming more entrepreneurial came from in our particular area. I wanted those services to be maintained, I wanted those people to be served, and I wanted to continue to make a difference in the community.
If we didn't care about the community mental health value system, it would be just as easy to downsize the organization and do whatever the money would pay for and say, the heck with the rest of it. But that's what drives it, I think, is that we really believe in that mission. And so our job as managers, as senior managers, is to find funding to help make it happen. That's the challenge.
The concept and vision of the Community Mental Health Center was basically abandoned by the major funders and policymakers in the early 80s, and for good reason. They had issues they needed to deal with. But the lack of funding made it very difficult to continue that mission. But in spite of that, some centers found a way to continue to provide those needed services to their communities. And that's one of the major reasons that MHCA was founded. The early founders hoped that by pooling talents and resources of the members, that together they could find ways to provide those needed services to the people of their communities. And I'm proud that MHCA was part of that.
Listen to some of the challenges that we've dealt with and how we've been successful in meeting those challenges. I'm sort of tempted to reflect back and say, hey, this movement worked. It made a difference.
I went in to get my cup of coffee in the morning at one of these, gas stations that also serves everything else, and I happened to have my logo jacket on from the center, and I walked up to and I paid, and she said, "Oh, you work for Circles of Care?" And I said, "Yes." And she said, "Oh." And I just like, uh-oh. And she said, she reached over and she grabbed my hand and says, "Thank you. I would not be alive today if I hadn't had your services." And she had a tear in her eye, and so did I. I don't know her name, don't know what. I know she's been working there now for about 6 months, but I can take that to my grave, because that's what it's all about. I don't need to know what she had or was a problem. I just need to know that agency took care of whatever it was. And that's the legacy we don't want to lose, wherever they are. That's where we want to go.